All right, welcome to week 5. Uh, and today we're going to talk about pharmacological aids in emergency intubation. So basically, we're going to talk about the drugs that we can use to facilitate some of the different airway procedures that we utilize and do and perform. So, lots of pharmacological agents are used to decrease the discomfort of intubation, to decrease the incidence of problems associated with laryngoscopy and intubation, um, and to make aggressive airway management possible for patients who may still be conscious and awake. So again, there are lots of reasons why we use drugs in airway management, and that's what we're going to talk about today. Most of the time, the drugs that we use for emergency medicine for anesthesia of the upper airway, or they're going to cause sedation of the patient to prevent them from bucking our tubes and so forth, or to cause paralysis to facilitate intubation, or to keep an airway patent, and also to decrease the complications that arise from intubation and the procedure of laryngoscopy. So if you don't know, the definition of anesthesia is the loss of sensation, especially the sense of touch in the skin or mucous membrane. The term analgesia is the relief of pain. That's why when we give analgesics, they actually relieve pain. So the technical word, if you take the word anesthesia, means without pain. So again, they will lose complete sensation, especially touch of the skin. Again, like I said, the mucous membranes. We talk about sedation. Sedation is the process of decreasing the patient's level of anxiety and consciousness. So again, giving them a more relaxed feeling, a more relaxed environment. Also potentially even causing an amnesic effect is going to be sedation. And when we talk about amnesia in general, is the inability of the patient to remember past experiences, and paralysis is the inability for the patient to move. So give me an example of an amnesic drug that a paramedic would utilize.
Versed.
That is correct, Versed. When we talk about Versed not only causes sedation because it is a benzodiazepine, it also has amnesic properties. So what that will mean is the patient will not remember anything from around that time period when you gave them the amnesic drug. Why would you think giving an amnesic drug, especially during airway management, would be beneficial?
I don't want to remember that.
I
would want to remember it.
Yeah, you don't want to remember that. Who wants to remember the fact of being knocked down, having a tube thrown down their throat, and not being able to breathe on their own and having something else breathe for them? So again, that is why we typically give them a sedative that is going to have some amnesic properties to it. A total loss of sensation in the entire body combined with a loss of consciousness, analgesia, sedation, amnesia, and paralysis is referred to as general anesthesia. All right. General anesthesia is kind of a scary concept, and that is why RSI, or rapid sequence induction, is considered to be a scary thing for medics to do, and is very controversial in the whole sense of medicine, because we are doing general anesthesia, for lack of a better term. You are giving them pain control, you're sedating them, you're giving them a drug to facilitate amnesia, and you're paralyzing. Now, why RSI is not necessarily or is not an approved skill in the state of New Mexico, it is still a paramedic skill that you need to learn and know about. But again, general anesthesia, again, that's what happens to you whenever you go under the knife. If you're going to have a knee replacement, they're going to put you under general anesthesia. You have your tonsils taken out, you're under general anesthesia. All right, done by an anesthesiologist in a controlled environment. And when we talk about this in EMS, you're not doing this in a controlled environment. Where are we doing this? The side of a road somewhere, in grandma's house, in the back of our ambulance, moving down the highway. So again, it's kind of one of those things that can be very, very scary. So induction refers to the period of time from the start of the anesthesia to the attainment of general anesthesia. So first, let's talk a little bit about local anesthesia. Local anesthesia is the loss of sensation in a specific region of the body, usually done by a nerve block or a topical anesthetic. Nerve blocks work very, very well for local anesthesia. However, they cannot be performed without significant experience and knowledge. All right, so if you think about like a digital block that's done, like if you cut your finger or something in those lines, or think also in the terms of when you go to the dentist, when you get an injection in your mouth prior to the dentist doing the drilling. Okay, that's going to be a nerve block. All right, blocking the nerve. You got to know the anatomy of the nervous system very well in order to induce this, and there's lots of complications that can arise from performing this. However, we do have topical anesthetics, which will induce local anesthesia through absorption and are generally most effective on the mucous membranes. Give me an example of a topical anesthetic we use.
Lidocaine.
Viscous lidocaine. All right. Viscous lidocaine is a topical anesthetic, and it's going to reduce the sensation. Now, it does not completely take the sensation away. What does it do? Simply just dulls it. It makes it not as intense. You still feel it, but the way I describe it is it's fuzzy. It feels like something's there, but there's something disrupting the nerve impulse, so it doesn't feel like it's a straight through impulse. But that is going to be local anesthetic when we talk about topical anesthetics. Topical anesthetics are underused in emergency medicine. The reason why is we don't think we have time to use them. We just grab them and grab the patient and go, and oftentimes overlook that. Pain management in emergency medicine, is, especially in the emergency medical services field, is generally underused in general. We have this mindset of not treating pain, not treating the patient's discomfort. But what we got to remember is, like, by using topical anesthetics, is we're going to significantly increase the patient's level of comfort and success of intubation if the patient is still awake. When will we use a topical anesthetic for intubation?
Nasal.
A nasal intubation. Absolutely. The patient's still going to be conscious. Granted, they may have an altered LOC, but if we're doing a nasal intubation, absolutely. We want to dull that sensation. So the proper use of topical anesthetics will decrease the incidence of gagging, which that's bad because gagging will induce vomiting. Vomiting potentially will induce aspiration, and we want to avoid that. So also we can lessen the cardiovascular response when we stimulate that upper airway, when we use dulled topical anesthetics. They're associated with very few complications and should be considered for the intubation of any patient with an intact gag reflex. If you're going to be intubating somebody with an intact gag reflex, you need to consider using a topical anesthetic. So again, whether that be viscous lidocaine or hurricane spray, whatever the choice of whatever your service utilizes, those are things that we need to consider.
What is hurricane spray?
Hurricane spray comes in an aerosol can. Basically, you spray it, and it induces the. It works a lot quicker than the viscous lidocaine does. Yeah, we'll talk about it here in just a few minutes. The most common agent used for topical anesthetic of the upper airways are the cane families. All right, so you've got lidocaine. You go to the dentist uses Novocaine. All right. So when we have the cane family, they are what induce this topical anesthesia for our patient. So lidocaine in concentrations of 2% to 4% is very effective for airway anesthesia. What's important to remember is your maximum dose is 3 to 4 milligrams per kilogram. 3 to 4 milligrams per kilogram is the max dose that you want to use for lidocaine. When you apply it to the surface of the mucous membrane, it induces anesthesia that begins in about 2 minutes and lasts anywhere from 30 to 90 minutes. All right, which is more than enough time to get your procedure done. The important thing to remember, though, is that you need to let it have some time to work. And that's why when I talked about nasal intubation, what did I tell you guys to do? I told you guys to use nasal pharyngeal airways, lubricate those up, and go in with the viscous lidocaine to dilate out of that narrowing, and also let that lidocaine have a little extra time to work. All right. Because again, initially, as soon as it applies, it doesn't have an instantaneous effect. It's got to have a little time to be absorbed, to be utilized. So lidocaine comes in a liquid is the most common way. When we talk about upper airway anesthesia, you can have the patient gargle and not swallow the liquid. So have them gargle it, spit it out. You can soak it into cotton applicators or spray it directly in the airway. Realize that spraying it is not as effective as the first two options, because it won't become in contact with the mucosa for very long. And again, just simply having them gargle it if they can works very well. But think about it: if you got a patient that you're considering using nasal intubation for, we're going to use nasal intubation to secure their airway. So you think they're really truly going to be capable of gargling without aspirating? Probably not. So that's not really going to be a valid option for us. But again, figuring out some way to apply it is going to be the key. Liquid lidocaine can effectively anesthetize the entire upper airway all the way to the vocal cords when you inhale it, or if it comes in a nebulized format. It can be inhaled through the mouth or through the nostrils. So again, considering nebulizing it, that is an option for you as well. But realize, not only are you going to get the back of the throat and down into the airway, where else are you going to get?
Bronchial.
The whole mouth, basically. Okay? So, but again, nebulization is an option to consider. Lidocaine jelly. And lidocaine jelly is probably the preferred method because it's jelly. It stays in one place for a longer period of time. It's not like a liquid that's going to fall off right off the bat. Again, we can put it on the nasopharyngeal airways. It's both a lubricant and as that anesthetic to reduce that sensation. And put it on our tube as we seen and experienced. So talking about medications used to reduce the complications from intubation. Before we move on to that, anybody have any questions about lidocaine?
Yes.
Yes.
How do we do that with nebulizing?
Put some in a nebulizer with a little saline. Let them inhale it in that way.
How much?
Well, your max dose is 3 mg per kilogram. So
do the max dose and just
no. Start at about 1 mg per kg and see how that works out. But again, you don't need to necessarily give them the full treatment. You just want to get the numbing effect to go in. But realize you don't want to exceed that 3 mg per kg dose. So the medications used to reduce the complications from intubation, there are complications, as we know, that come along with intubation. And probably the biggest one that we think about is hypoxia. The best way that we have to decrease hypoxia is to pre-oxygenate the patient and limit the duration of any single attempt to no more than 30 seconds, like we've already talked about. However, that's not necessarily going to be the end-all be-all. Realize, like I talked about, we want to utilize true resource management. Use our partner to help us in the facilitation of that intubation, while monitoring the vital signs and watching our patient. So, normal hemodynamically stable patients that breathe 100% oxygen for 5 minutes can take 5 to 6 minutes to desaturate to 90%. And I want you to think about this concept for just a minute. This is where we get into our nitrogen washout phase. Okay, when I talked about if we give them 100% oxygen by BBM, or even if we slap a non-breather mask on their face at high flow oxygen level, and because they're actually ventilating well on their own, if you can have them on that 100% oxygen, what's going to happen is you're going to displace all of that nitrogen with oxygen, and you're going to increase their PaO2. All right. Now, in a normal patient, what that means is when you go in, you got at least 5 to 6 minutes, sometimes upwards of close to 10 minutes, that they will maintain an oxygen saturation of 100% even if they're not breathing. Okay? Now that's kind of a hard concept to think about. But if you've got all of that, because they've got, what do they have? They have all of that plasma oxygen that's there, right? That's able to facilitate gas exchange. So when you induce them during or go through the induction phase of anesthesia, if you're doing an RSI procedure, or even simply if you're intubating, that buys you time to play around. And I don't mean play around in the sense of play around, but I mean it buys you time to get your airway in, so that you're not sitting there watching the clock and counting seconds necessarily to get the procedure done. If it takes you 40 seconds to get them intubated, okay, because again, you're buying that time. But the thing to remember, this is on normal, hemodynamically stable patients. Somebody like me, well, I'm not a normal patient. Why? I'm obese. All right? So I am not going to be able to maintain that as long as a normal person. So if you have somebody that's ideal body weight, maybe a little bit heavier than ideal body weight, normal, healthy patient, normally, they're going to be able to do that. If you've got somebody that's got chronic health problems, COPD patients, things such as that, obese patients, they are not going to be able to, they're not going to have that 10-minute period there or 5 to 6 minute period of 100% saturation after they quit breathing. What you're going to find is they're going to desat very quickly. Now, on the same note, like I said, they will stay for that period of 5 to 10 minutes. They will stay within 100% oxygen range. But what happens as soon as they hit that mark, the plateau, they're going to drive off the hill, and they're going to desat very quickly. You're going to see them go from 100% to 90% to 80% to 70%. Once we hit a 90% oxygen saturation, we're going to drop into the 70s, 60s super quick, almost in the blink of an eye. All right, it takes some time to get from 100 to 90, but once we get to 90, it's quick. You understand that concept? Okay. So we're not only going to intubate hemodynamically stable patients, so we should do our best to hyperoxygenate every patient that we encounter. So to decrease intubation-induced hypoxia, conscious patients should breathe 100% oxygen for at least 5 minutes, or ventilate hypoventilating patients for at least 2 to 3 minutes with a BBM in order to get their saturations up as high as possible, and again to form that nitrogen washout. So the other thing to remember is stimulation of the glottis associated with intubation can cause dysrhythmias. Okay, because again, the vagus nerves down over in those parts. We can get a substantial transient increase in intracranial pressure. Something else to consider, all right, by doing that. So when we go through, if you have somebody that's got a head injury or something in those lines, or even if they don't have a head injury, realize that stimulation back there of the glottis is going to potentially increase intracranial pressure. So that's always something that you need to have in the back of your mind. So anybody that's got a closed head injury or intracranial pressure or cerebral hypoperfusion, you need to be concerned about. We'll talk about some methods here on the next slide to reduce problems with head injuries or increased intracranial pressure. So IV lidocaine is going to be your pre-treatment agent here. Okay, giving them IV lidocaine. What IV lidocaine will do is it will dull the cardiovascular and intracranial response to laryngoscopy and intubation. It does not provide upper airway anesthetic though when we give it IV. So, but what it will do is it will reduce the effects or the effect of intracranial pressure. We're not going to get the dramatic response there. So as a rule, tight heads, tight lungs, we're going to pre-treat them with lidocaine. Okay, lidocaine and a dose of 1 mg per kg. All right, again to fix that problem.
Is this for? Is this gonna be different than the Propofol anesthetic? Is it 3 to 4?
Yes.
This is 1 mg per kg.
Is it a bolus or a push? on this IV Lido?
Bolus and push mean the same thing.
Well, I mean, is it a rapid push or do you just infuse it?
No, you push it in. It's a IV push, not rapid. You don't slam it in, but just normal flow, slow IV push. So sedation should be considered any time you need to intubate a conscious patient. All right. Now, realize that we do not do RSI in New Mexico, so I am going to reiterate that point. All right. So don't think you're going to be out sedating people and intubating them when you get your paramedic license. But you do need to understand this if you work in any other states and possibly do this, and this could potentially come into scope one of these days. So you need to talk about that. And there's more than just RSI. There's RSA as well. Rapid sequence airway, which is done by some services in the state, which we'll talk about a little bit later on. But again, we're going to talk a little bit about sedation here and RSI. Sedation should be considered, again, anytime a conscious patient's going to be intubated. You need to sedate them. What that's going to do is it's going to reduce the patient's anxiety. It's going to induce amnesia and decrease the patient's gag reflex. Now, under week 1, you guys have an RSI protocol. This is the protocol that you will learn and you will follow. The protocol is adopted from AeroCare. It's AeroCare's protocol. The reason why I have you all learn AeroCare's protocol is there's a potential that some of you may get to fly with AeroCare a little bit later on. And plus, it's just a protocol to use and to follow. All right. There's lots of different options out there, and we'll talk about different drugs. But the drugs that I want you concentrating on and the doses I want you concentrating on are based off of that AeroCare protocol, or RSI protocol that's posted on Blackboard. All right. So, sedatives, medications have a great potential to help, but can also hurt the patient if you don't use them properly. Realize that using sedatives, we can undersedate the patient, which basically is still going to cause problems. The patient's still going to have anxiety and other issues going on. And we can over-sedate the patient and totally cause their airway to crash or have some of the toxic effects of using some of these drugs and some of the nasty side effects. So realize you want to use your proper dosages and you want to pay attention to that and make sure that the patients do not have any contraindications to any of the that we're going to utilize. So again, under sedation can result in poor patient cooperation, gagging, and incomplete amnesia and of the event. Over sedation can result in uncontrolled general anesthesia, loss of the airway reflex in general before you're even ready for that to happen, respiratory depression, and potentially hypotension, which is a whole other problem we're going to have to deal with. All right. So we talked about sedation. All right. So sedation drugs could be anything from your benzodiazepines, whether it be Versed is probably the most common. Etomidate is another sedation drug that may be utilized. Now, when we talk about induction agents, they're a broad category of pharmacological agents that, given in sufficient qualities, induce that general anesthesia. It's difficult to define sedation in absolute terms, but again, the term sedation is going to refer to the patient's response to these induction agents. So light sedation occurs with small amounts of medication given to decrease anxiety and increase cooperation. The more medication you give, the more dramatic the effects are going to be. Euphoria, amnesia. The patient will get sleepy and then lose consciousness. All right. Sometimes the patients just get downright funny when you give them the induction agents. All right. When you give them drugs like Versed or whatever, because again they lose. They're in a state of euphoria. They're happy. All right. So they've been given that. They basically don't care. All right. But again, the amount of sedation that you're going to want to use is going to vary depending on the situation. So the level of sedation is going to be based on the dosage that we give and utilize. The patient's response, um, the patient's response to these medications is dose dependent, and again, it's going to be very variable based on each and every patient. If you have somebody that uses benzodiazepines on a quite regular basis, they take a Valium every day, or they take Xanax, or anything in those lines, realize you may have to give a higher dose to get the effects that you want. So there's two broad classes of sedatives that we commonly use. Analgesics decrease the perception of pain, and hypnotics induce sleep and decrease anxiety, but they do not reduce the pain. So we've got to give a combination of both. All right, we've got to give a combination if we're going to RSI someone or do an RSA procedure. We have to be able to utilize both. The overall goal, an overarching goal, is to give as little medication as possible to achieve the desired patient's response. If we're going to treat the anxiety or produce amnesia, we give a sedative or a sedative hypnotic. To treat pain, we give a sedative analgesic. Okay? So we're going to give a combination of both, though, if we're trying to induce the effects of a general anesthesia. Everybody with me so far? So, commonly used sedatives in emergency medicine. We have our sedatives like haldol, ensipine. We have our benzodiazepines, which are sedative hypnotics, like diazepam and Versed, which Versed is probably much better because, again, it does have that amnesic effect as well. We have barbiturates that are out there, like pentathol and Revitol, not commonly used as much anymore. Opioids have a sedative analgesic effect, specifically fentanyl. We'll use that quite frequently. Propofol is another one that's out there. You've probably all seen Propofol drips before, maybe in the hospital. It's a white substance they give it. Basically, Propofol is a great drug because as soon as Propofol hits you, it knocks you out. As soon as it stops, you start waking back up.
That's what killed Jackson.
That is correct. That is what killed Michael Jackson, is Propofol. So again, I knew you guys had all heard of Propofol before in one way or another. If given appropriately and properly, it is a very safe and good drug. However, if given by someone for just some sleeping issues and in high doses and unmonitored, again, it does have its complications, just like any other sedative hypnotic. All right, Etomidate is very, very common, although Etomidate is starting to fall out of favor for RSI. And ketamine. Ketamine is a sedative, analgesic, and a hypnotic. Ketamine works really, really good for kids. All right, and that's the most common time that you'll probably see ketamine used is a lot of times in pediatrics. So, buprenorphines are potent, effective sedatives. Haldol, you probably all heard of Haldol. It's used for psych patients very commonly. And ensipine, because they do induce that anxiolytic effect of sedation. Again, they are good choices. Specifically, Haldol. Haldol induces a very quick sedative response that works out quite well. They calm agitated patients. Trauma patients are combative. It works very well on them. Patients experiencing alcohol withdrawal it will work on. And again, most commonly is what we think of them as patients that are in psychosis. They do not produce apnea and have little effect on the cardiovascular system. And that's another reason why they are used so commonly. Droperidol is faster acting than Haldol, And again, it's generally preferred for emergency situations, although you will see haldol used more frequently in this part of the world, most likely. Um, Usually, you will combine them with an opiate or another benzodiazepine because they do fall in the class. They do have some antiemetic effects as well, but they're not generally recommended for the induction of anesthesia. Again, they're just used for sedation primarily. Then we go to the class of benzodiazepines, which are sedative hypnotics. So you got Valium and Versed, or diazepam and midazolam. They produce muscle relaxation, mild sedation, and are used extensively as anxiolytic medications. As we all know, they have anticonvulsant properties. They provide antegrade amnesia. Specifically, Versed, Valium doesn't work quite as well, but they will provide amnesia of everything surrounding the time, not just from the point you push it on, but from a little bit before even you push the medication. You will get an amnesic effect that takes place. All right, you guys have all heard of probably Rohypnol before, which is not an approved medication, but Rohypnol, the date rape drug, falls out of the same classification. All right, it is a benzodiazepine. Okay. The thing to remember is midazolam is 2 to 4 times more is potent as diazepam. It's factor acting and has a shorter duration of action. So again, that's why we typically pick Versed to be used. Now, if we do RSI someone, oftentimes what we're going to have to do is we're going to have to give them the Versed to induce them, and after we get them set up, then we get to calculate a drip and set them on a Versed drip to keep them under. Which you guys have all learned how to do drips in Rodney's class. And again, you get to play with that a little bit in laboratory. So the respiratory depression and slight hypotension are side effects of benzo administration. Hypotension is a very, very common side effect of giving the benzos. Romaticon is the equivalent of Narcan for benzos. All right, it can reverse the effects of the diazepam and midazolam. It really doesn't have any side effects if given in high doses. Here's the problem with giving romaticon, though. If you give romaticon and then you need to sedate your patient, you're not going to be able to because it's going to be on board and in their system. All right. So, giving romaticon's kind of a controversial kind of thing because sometimes when you give that effect, you may need to resedate your patient after the fact if you need to reverse it. Then you're kind of up the creek without a paddle because when you give a benzo again, it ain't going to work as long as the romaticon's in the system and active, which is for a couple of hours. So, again, romaticon, kind of question its use before you actually use it. Next, we move into the family of barbiturates. They're sedative hypnotics and have a long history as an induction agent. They're probably the most commonly used in the operating room. Pentathol is a short-acting and causes a rapid onset of profound sedation. If you want to know what barbiturates are commonly used to treat seizures. Like phenobarbital is a barbiturate. Okay, basically they really make you really, really drunk is what they basically do. All right. Revitol is a short-acting and twice as potent as thiopental. Revitol is very, very commonly used in airway management procedures in emergency medicine. Again, it works very, very quick and it's short-acting. Which short-acting in emergency medicine is always a good thing, especially when we talk about short-acting in EMS. Why would short-acting drugs be good for us? What happens if it doesn't work and we're not able to intubate somebody, or we aren't able to facilitate getting an airway and we have them completely paralyzed and down and out? We want our drugs to wear off kind of quick and bring them back up in that sense. Because otherwise, bagging for an hour and a half, or whatever, can be a very long time.
Ventilators.
What if you don't have a ventilator? What if your ventilator explodes?
Suing the company.
Do what?
Gonna sue the company there.
gonna have a few
Well, that
more
fixes you after the fact down the road. It doesn't fix you right now. All
If my
right.
ventilator explodes, then I'm going to be a patient too. You'll be having a heart attack.
Yeah. So barbiturates cause significant respiratory depression and a drop in blood pressure. They actually cause a very profound drop in blood pressure, even in the normal bulimic patients. A lot of times it's irreversible as well. So giving them that drop and you have their blood pressure drop, you're giving them a bolus, is not going to bring that pressure back up. So again, it's kind of one of those things. It's why they're commonly not used in EMS, because again, they do have some nasty side effects. Again, it's one thing to have a nasty side effect in a controlled environment. It's another thing to have a nasty side effect in an uncontrolled environment. So opioids, potent analgesics with sedative properties. Fentanyl, now fentanyl are both very, very common airway management drugs in the opioid classification. Fentanyl is 70 to 150 times more potent than morphine. Realize that. But it has some good things to it. It doesn't affect blood pressure. It's short onset and short duration, which works for us. But again, it is a lot more potent than morphine in terms of dose. That's why we give it in terms of micrograms. We don't give milligrams, we give micrograms of fentanyl. All right. Often though is less potent than fentanyl, but has a faster onset of action and a shorter duration. The main advantage to using it over fentanyl is it is less fat soluble and it gets out of the body faster. Fentanyl gets stored in the fat and it'll be there for quite a while, so it does have a longer time in the body. As we know, opioids cause profound respiratory and central nervous system depression and can cause hypotension and bradycardia. So the main benefit of opioids is their effects can be reversed with naloxone. But realize when we give fentanyl, or any of the synthetic opioids, a lot of times we got to give much higher doses of Narcan to reverse the effects, because they are synthetic, and the Narcan doesn't work on them quite as well. All right. So is everybody with me so far? All right. Now Propofol or Diprovan, or Michael Jackson milk, whatever you want to call it, is a potent sedative hypnotic that has been developed as an alternative to benzos and barbiturates. Like I said, it has a very, very rapid onset, a very short half-life, little hangover effect, and it has powerful antigrade amnesic properties. All right. And it doesn't really affect the patient's heart rate very much. So that's why it's so great to use. Basically, literally, you have it in somebody. You have the drip going into their arm. You see it hit their arm. They go night-night. You stop it. It quits going in their arm. They wake up. That's how it works. Okay? It works very, very well. And again, like I said, it wears off very, very quickly. It doesn't affect heart rate as bad, but it does have some significant cardiovascular effects, blood pressure and so forth. So that's why we've got to be very, very careful with it. And ultimately, that's what killed probably Michael Jackson. And it can cause respiratory depression. But again, we're using it for airway management. So we're getting prepared to manage their airway. So that's not quite such a big issue for us. Etomidate, non-narcotic, non-barbiturate, but it is a hypnotic sedative agent. It's fast-acting and short duration, and that's oftentimes why it is used so frequently. So it has decreased the cardiovascular complications of some of the other medications. It does not cause histamine release and bronchoconstriction, that occurs with some of the other drugs. The high incidence of uncomfortable myoclonic muscle movement is associated with the juice, though. So they'll get twitching when you use it. So it'll make your patients quite sore after they recover and come out of the anesthetic after you've used it. So again, that is one of the nasty side effects with it. Again, like I said, Etomidate is kind of falling out of favor, not quite used as commonly anymore. Ketamine, Ketalar, street name Special K. Alright, is a fast-acting drug. It has sedative, analgesic, and hypnotic qualities. Alright, you're going to find out why people like ketamine so much. Alright, because it was created in the laboratory, and it is a form of PCP. Alright, so we all know what PCP is. It's not commonly used in emergency situations in adults because it causes nightmares. And when we talk about nightmares, I mean nightmares. Right? It's like PCP. Right? You're going to see people's faces melting and all kinds of other things. Patients do not do well on it, all right? Especially adults. But it does work very, very well in kids. It works very well in kids. Protective airway reflexes are maintained with the administration of ketamine, and there's little respiratory depression following its administration.
The kids not have nightmares?
No, it does not cause the nightmares in kids, but it does in adults. It's the way our brains are wired.
Sick and twisted yet?
Yeah, I guess. Yeah, they're not sick and twisted,
Might
but
work
it has
on some
to do.
kids.
It has to do with the chemical balances in the kids' brains. So, any questions on those guys? Now let's talk about a little bit about paralytics.
I have a question on Etomidate.
Sure.
Do you give that in conjunction with the paralytic to keep them from twitching?
You're going to give all of these in conjunction with a paralytic. And that's where we're moving on to next is paralytics now.
Okay.
So, yeah, all of these, this is a step, a sequence. These are all the drugs you're going to administer. You're going to pick one of the sedatives. You're going to pick a pain reliever. And you're going to pick a paralytic to give. And you got to give a conjunction of all three. All right. So, paralytics, cerebral hypoperfusion make patients combative and uncooperative. Hypoxia can make a patient a danger to himself or herself or others. So the way we treat that is a lot of times with aggressive airway management, we may have to do this. So patients that are combative, we can't really manage their airway. So we may have to consider paralyzing them to do this. Or we may need to consider doing an RSI procedure because we know that it's the anticipated course of action. The patient's going to lose their airway. It's better to fix their airway before they lose it, especially if you have somebody that's got a head injury or something in those lines. We may need to, again, knock them down. COPD patients that are struggling to breathe. Again, all of these are going to be things that maybe make us have to consider doing an RSI procedure. So chemical paralysis combined with sedation make it easier for us to intervene and secure their airway. We can oxygenate, ventilate, and intubate the patient without using restraint. The patient who loses their protective airway reflexes will tolerate blading them with a laryngoscope, and they're not going to gag all over the place. Not everybody can take things, or most patients have a gag reflex. There's very few in the world that do not. So chemically inducing paralysis is aggressive and is relatively new in pre-hospital care. And it's very, very controversial in pre-hospital care. There's data that shows that it's bad. There's data that shows that it's good. All right. Again, if done properly, it's an excellent procedure and it's very beneficial to the patient. If done improperly, it kills your patient. So again, we have to really, really follow the rules on this. We should never consider RSIing or paralyzing a patient or doing anything in those lines unless we are confident in our ability to use them safely and maintain a secure airway after achieving the paralysis. So neuromuscular blocking agents. All paralytics affect every skeletal muscle in the body, including the diaphragm and the intercostal muscles. They paralyze it all. All right. When you paralyze a patient, we're going to make them apneic because their diaphragm's not working and their intercostals aren't working. The patient can't move, breathe, talk, or blink. However, they can still feel pain, and they can still hear you and see you and know what's going on around them. That is why we give them sedatives and pain medications before we paralyze them. Because again, if you don't do that and you paralyze them, basically they're there but they can't do anything about it. Once we paralyze the patient, we are completely responsible for that patient's breathing. Paralytic agents do not affect the cardiac or smooth muscle. They have no effect, like I said, on level of consciousness. The patient is going to be fully aware and can hear, feel, and think. So you've all probably heard of patients waking up on the operating table and they can't move, they can't hear anything, but they know and they can feel the surgeon cutting on them. All right? You think about laying in the back of an ambulance, or you think about anything in those lines, and you can't move, you can't do anything, but somebody's shoving a tube down the back of your throat and shoving a blade down there and prying in your mouth. That's something you really want to remember, something you really want to experience, and that's why we got to make sure that we follow the procedures on this.
So, is there any way to assure that you sedated them correctly?
You give them their
Just besides the doses, that's the only thing.
the doses and watch. So things you're going to see. If you give them the paralytic and you're doing the procedure, and you all of a sudden see their heart rate start to spike. That's probably going to tell you that they're feeling pain or seeing things. You see their blood pressure go up. Those types of things. You see the patient's eyes moving around and looking at you. That's going to tell you that that there's some issues going on there.
So they can't blink, but they can move their eyes?
They can move their eyes a little bit, yes. And you can see that the difference in the dilation of the pupils and so forth, it's not going to affect the optic nerve. So,
what about a person with a nystagmus? How are you going to differentiate that from just regular eye movement?
you're going to have to look at other things. You're talking about an anomaly there. Anomalies, you can't address every anomaly. You're going to have to look at the other symptoms. You're going to have to look at their blood pressure. You're going to have to look at their heart rate.
So just the reactivity of the nerve would be...
Right, yes.
So do you build a drip at that time and give it to them, or you just give them another dose?
You're going to have to give them another dose. You're going to have to give them another dose, and then you're going to have to consider giving them a drip. Right now, all of this stuff is going in a rapid. That's why it's called RSI, rapid sequence induction. You're moving very quickly. You're giving the pre-sedative, you're giving the sedative, you're giving the pain medication, and then you're paralyzing them. And all of this is happening in a matter of minutes. You guys have all probably seen a patient RSI when a flight crew shows up or something along those lines. All of this is done very, very quickly. There's nothing rapid about the procedure in the sense that there's a lot of prep work that goes into it. But once the procedure starts, it's all done in a matter of a couple of minutes. Because again, to get that done. So if you start to see those effects when you're going into paralysis, and you're starting to see the increase in heart rate and all that other stuff, that's when you know that you probably need to give them either another sedative or maybe some more pain meds to get them down. So all paralytic agents affect the neuromuscular junction, which is the motor nerve cells, comes to close proximity to the motor end plate of a muscle fiber. So again, it's going to affect the motor nerves. As an impulse to contract reaches the terminal end of the motor nerve, a neurotransmitter, acetylcholine, is released into the synaptic cleft. Acetylcholine is then going to diffuse across the synaptic cleft and bind to the receptor side of the motor end of the plate. This should all be reviewed from pharmacology for you. Acetylcholine occupying the receptor sites triggers the changes in the electrical properties of the muscle fibers, and we call that depolarization. Alright. So medication used to induct paralysis is all function at the neuromuscular junction and are referred to as neuromuscular blocking agents. There's two kinds. There's depolarizing and there's non-depolarizing agents. So first thing we'll talk about is depolarizing neuromuscular agents. So the depolarizing neuromuscular blockers, they will competitively bind with acetylcholine receptor sites, but are not as affected as quickly by acetylcholine esterase. They cause depolarization of the muscle and prevent future signals for depolarization from having an effect because all of the acetylcholine receptor sites are already occupied. So basically, they sit there and they block it. They block any further junction or any further acetylcholine from coming in contact. That's the way a depolarizing neuro agent works. There's only one of them that we give. That's succinylcholine. Succinylcholine is most commonly the one that we the paralytic of choice for our patients. But succinylcholine is going to be the only one that we actually utilize. So when we use depolarizing neuromuscular agents, we're going to see fasciculations during administration of the succinylcholine. Anybody that has hyperkalemia, we don't use succinylcholine with them. If you have burn patients, it's going to be a contraindication for using succinylcholine. If you got a patient that renal patients, we're not going to want to use succinylcholine. Because its structure is similar to acetylcholine, it can cause bradycardia, especially in children. And the way, so that's something that we've got to consider in that. When we have children, if we're going to use that, we need to premedicate them with atropine, if possible, to prevent that bradycardia from taking place. We'll give them a dose of atropine prior to giving the succinylcholine. So the reason why we like succinylcholine and the depolarizing neuromuscular agents is that they have a very rapid onset, 60 to 90 seconds, and their paralysis is short acting. Well, if you want to call 10 minutes short acting. But 10 minutes can seem like an eternity if things are going bad. However, that's compared to our non-depolarizing that lasts anywhere from 45 to 60 minutes. 10 minutes is a short period of time to deal with. So if we don't get their airway secured, we've got to support their ventilations anyway. So this is going to give us a shorter period of time that we have to deal with that. So any questions on our depolarizing?
So that'd be something like you used to maybe initially?
Yes, and then after the fact, then we're going to consider giving something like vecuronium or something of those lines, which we're going to talk about some of the other drugs here in just a second. This is good for the initial procedure itself, not necessarily keeping them down. So our non-depolarizing neuromuscular agents bind to the acetylcholine receptor site, but they do not cause depolarization of the muscle fiber. When given in sufficient quantity, the amount of non-depolarizing medication exceeds the amount of acetylcholine in the synaptic cleft, and the critical threshold of depolarization can be achieved. All right. So that's the difference between depolarizing and non-depolarizing.
So it just overwhelms the site.
Yeah. So when we talk about the depolarizing, what do they cause to take place? They cause it to actually fire, which is why we get the fasciculations a lot of times when we give the depolarizing. Okay, and then they block. Okay, these guys just inundate the whole system. They don't give it a chance to fire, but they block any further impulse from taking place. All right, and that's also why they last longer. So there's lots of non-depolarizing. There's only one depolarizing, but there's lots of non-depolarizing. That's vecuronium, pancuronium, antracrum, and terbiquinone. What we'll commonly see, most commonly, is vecuronium. Occasionally, we may see pancuronium as well.
Easy speed rider.
So non-depolarizing agents have a rapid onset of about 3 to 5 minutes, all right, and a longer duration, anywhere from 30 to 90 minutes, all right. So these agents should not be given before the patient's airway is secured, and that's the key. We use succinylcholine first. Then after we get them intubated and get the procedure done, then we will hang a vecuronium drip or a pancuronium drip, whatever the drug of choice is, to keep them under. Okay? But this is not going to be your primary choice. Now, however, if you've got a patient that's hyperkalemic or you suspect hyperkalemia in them, we may use vecuronium as actually our induction agent, or not our, as our actual initial paralytic as well. But again, if you're going to do that, you need to make sure that you're going to be able to secure that airway and get that airway under control. So rapid sequence intubation. Okay, like I said a minute ago, it's rapid sequence once we get started. Prior to that, it's not rapid. There's a lot of prep work that goes into doing this. All right. All patients presenting to hospital emergency departments or encountered in the pre-hospital situations are presumed to have a full stomach. That makes a complication for us. All right. In the OR, well, the patient's been NPO for 12 hours, so their stomach's empty. They're not going to puke all over the place. So we don't worry about aspiration so much in the OR. In the field, we have to anticipate that. So we've got to do steps to decrease the risk of aspiration. So once you paralyze someone, you've lost their ability to control that. So they're going to vomit. All right. So you need to have suction ready. You need to be prepared to do the Selleck maneuver or whatever to make sure that they don't aspirate any stomach contents. So rapid sequence intubation presents a culmination of integration of all your airway, problem solving, critical thinking, and decision-making skills into one procedure. It includes safe, smooth, and rapid induction of deep sedation and paralysis, followed by immediate intubation. So we're going to use it for conscious or combative patients, and we need to secure the airway on. So before we do this, prepare the patient and equipment, explain what you're doing to the patient, and then let the patient know that they will be asleep during the procedure. Make sure the patient understands that they will not feel or remember anything, and you want to make sure that you have the patient on a cardiac monitor or pulse oximeter to monitor vital signs. When we're doing this, we have time to prepare. All right, this is when we have time to look at their Malin patty, look at the 3-3-2 rule, follow the lemon rule. Okay, because we're not just getting in there, blading them, and going to town. We actually have time to evaluate all of this. You need to do that. Do you really think you want to RSI somebody with a Malin patty of 4?
Probably not.
Probably not. All right. If you got a patient that looks like they could eat corn on the cob through a picket fence because they got an overbite from you know where, you think you want to RSI them? Yeah, be a little cautious of that. All right, because again, you see these complications, that may not be the patient you want to use, all right, or do this on. Because like I said earlier, this needs to be the patient that you are confident that you're going to be able to get the airway on them. All right, and always make sure that you have suction and all your equipment available and ready to go. You want to make sure that you pre-oxygenate your patient. Spend that time doing the 5 minutes of hyperoxygenation on these patients. We want to increase the FiO2 to 1.0 is what we want to do. We want to get them at 100% oxygenation. So we want to premedicate the patient. We want to give a defasciculating dose of a non-depolarizing neuromuscular blocking agent. And your defasciculation dose is a low dose of succinylcholine, which is going to, of vecuronium, which is not going to induce complete paralysis, but it's going to prevent fasciculations, so the patient doesn't shake during the procedure. So you give a low dose of your non-depolarizing neuromuscular blocking agent. Tight heads, tight lungs, consider giving lidocaine. Dry secretions, or in pediatric patients, we may consider giving them atropine, again, to keep their heart rate up. We want to prepare to sedate and paralyze, administer a sedative agent, an amnesic. As soon as we give that, and then we're going to induce paralysis. All right. So we're going to give them, pre-treat them first, then we're going to give them a dose of Versed, Etomidate, whatever drug you choose, and then you probably want to give them a dose of fentanyl as well. All right. Again, you want to give them a sedative and a pain management drug. All right. And then give your paralyzing agent. Paralysis will begin in about 30 seconds, and it takes about 2 minutes for it to fully take place. Okay, so 2 minutes for it to take place. Apply your cricoid pressure, so again they don't run the risk of regurgitation. Intubate. Intubate the trachea as carefully as possible. Confirm your tube placement and release the cricoid pressure. And then after that's done, we're going to administer a non-depolarizing neuromuscular blocker for long-term paralysis. Administer the sedative to the patient's blood pressure is adequate, and monitor their heart rate and blood pressure. Keep them comfortable, keep them under. All right? Now, before we close this lecture, as we make sure and talk about as well, we cannot do RSI in New Mexico. It's not a paramedic skill. However, like I told, how we talked about during intubation, what happens once you intubate that patient and you start to correct the problem and the patient's starting to come back to and wake up? Is it okay for us to sedate and keep the patient under at that point in time? Yes. And what do we have to facilitate that? For sed and what else?
Fentanyl.
And a fentanyl, a pain medication. Keep them under. Okay? Now, vecuronium and succinylcholine, is it in your scope of practice?
Yes, we just don't carry it.
It is in your scope of practice for long distance transfers, for administration during transfers. Okay? So, study your RSI protocol under week 1 in Blackboard. Make sure that you learn those dosages and learn that procedure. Because again, we will practice this in lab. Any questions? All right.